This lecture is about the pediatric hematologic disorders. Blood plays a vital role in metabolism because RBC, WBC, platelet, and plasma. Although plasma is not a major site of hematologic disease, generally blood does the following. Number one, they transport oxygen and nutrients to the cells. Second, they remove waste products or carbon dioxide from the cells. And third, they initiate blood coagulation when vessels are injured. So, as a result of these functions, any alteration in either substance or function can have an immediate and life-threatening effect on the functioning of the body system. Again, when we say alteration, it would include the hematologic disorders and blood dyscrasias, which means they originate in the bone marrow. Mostly, blood dyscrasias originate in the bone marrow. When you say there's an alteration in substance, it's usually an increase or decrease in amount. And when there's an alteration in function, the blood products are incorrectly formed. Let us review the hematopoietic system. The blood components originate in the bone marrow. They circulate through the blood vessels and are ultimately destroyed by the spleen. Let us further discuss the blood formation and the different blood components, as well as the process of blood coagulation. Erythrocytes or RBCs are formed because of the hormone erythropoietin. It is produced by the kidneys, and production is stimulated whenever there is hypoxia. Hemoglobin is the very important RBC component which carries oxygen. For hemoglobin to effectively carry oxygen, it needs the help of iron. Hemoglobin breaks down every 120 days. That's the adult hemoglobin. And one of its breakdown product is indirect bilirubin. Indirect bilirubin must be converted to direct bilirubin or unconjugated bilirubin to conjugated bilirubin. The conversion is because of the glucuronil transferase produced by the liver. When the indirect bilirubin rises, it may show signs of yellowing or jaundice in the skin. Leukocytes or white blood cells are important cells that defend us against antigen invasion, while thrombocytes are important for hemostasis and primary coagulation. Blood coagulation or blood clotting is the process by which blood changes from a liquid to a gel, forming a blood clot. This potentially results in hemostasis. Hemostasis is the body's first attempt to stop bleeding. It is the cessation of blood loss from a damaged vessel followed by repair. When this happens, healing will then occur. Box 44.2 shows the different blood coagulation factors, and figure 44.1 shows the steps in blood coagulation. Remember also that effective blood coagulation depends on a complex series of events, including a combination of the intrinsic and the extrinsic pathway. The intrinsic pathway are plasma-related factors. These are factors 8, 9, and 12. While the extrinsic pathway is tissue factor 3 as an incomplete thromboplastin plus factors 7 and 10. Altogether, they form factor 5. Assessment and therapeutic techniques. Bone marrow aspiration and biopsy. Bone marrow aspiration is a procedure that involves taking a sample of the liquid part of the soft tissue inside your bones. Bone marrow, as a review, is the spongy tissue found inside our bones. Biopsy, on the other hand, is where the aspirated bone marrow sample will be tested. It is tested for the presence of abnormal cells. Among neonates, this is done usually on the anterior tibia. In younger children, probably on the iliac crests or spine. In the adults, this can be done in the sternum. Second is blood transfusion. Usually, blood transfusion is 15 ml per kilogram of body weight. Nurses should always check for the correct rate. This was previously discussed in the neonatal interventions before. It's also important to cross-match, making sure that the blood type to be administered is correct. While giving, the nurses must also check for transfusion reactions. Watch out for transfusion reactions such as chills, fever, tachycardia, dyspnea, wheezing, pruritus, muscle cramping, jaundice, or bronze skin. Once transfusion reactions are seen, the blood transfusion must be stopped right away. Third is hematopoietic stem cell transplant. It is the IV infusion of hematopoietic stem cells from bone marrow aspiration or peripheral or umbilical cord from a donor. It is compatible or said to be compatible with the donor when human leukocyte antigen or the HLA of the donor and the receiver matches. It could either be in allogenic form, synergenic form, or autologous form. Allogenic is from a sibling. Synergenic is from a twin, while autologous is from your own cells. Splenectomy is the removal of the spleen. The spleen, as a review, removes damaged or aged blood cells. For example, there is a disease called sickle cell anemia where the spleen does this continuously and causes anemia. Splenectomy will not cure the problem, but it can help limit the anemia. These are the different pediatric hematologic disorders that we will discuss: iron deficiency anemia, G6PD deficiency, sickle cell anemia, ITP or idiopathic thrombocytopenic purpura, and hemophilias. These do not occur at equal rates in all countries, since some may be inherited. As an example, the sickle cell anemia is very common among the African and Americans. Also consider cultural influences when dealing with these disorders. Another example, Jehovah's Witnesses may refuse blood transfusion as a common blood therapy. Iron deficiency anemia occurs when intake of dietary iron is inadequate. It's the most common form of anemia in infancy and childhood. Remember that there are more iron needs in 9 months to 3 years and then adolescents. This is about 6 to 15 milligrams daily. Most iron in the body is incorporated in hemoglobin. So if inadequate, it prevents proper hemoglobin formation. Again, without adequate iron, hemoglobin cannot be incorporated into RBCs. RBCs are both small in size and pale. This is because of the stunted hemoglobin. Box 44.6 shows a child with iron deficiency anemia. The mark of this anemia is pale conjunctiva. There is also poor muscle tone and reduced activity with extended deficiency. The heart may also enlarge as it beats faster in an attempt to supply body cells with more oxygen. Management. Add iron to formula, food, or by vitamins by age 4 to 6 months. Give oral iron with citrus juice or orange juice and on an empty stomach. This is for better absorption. If given on a child in liquid preparation, use straw. This will mask the taste and prevent staining on the teeth. Also, if iron has been absorbed effectively, stools will turn black. Ferrous sulfate can be given in 4 to 6 weeks. Again, increase vitamin C to enhance iron absorption. If there is mild anemia, it can be given 3 milligrams per kilogram per day in 2 divided doses. But for severe anemia, 4 to 6 milligrams per kilogram per day in 3 divided doses. Second is to provide iron-rich foods. The iron-rich foods are stated in the slide. Among all these, liver is the best source of iron. Glucose 6-phosphate dehydrogenase deficiency or G6PD deficiency. It's a sex-linked recessive trait characterized by a lack of G6PD enzyme resulting in premature destruction of RBCs. When you say sex-linked recessive trait, males mostly manifest the disease. G6PD is necessary for maintenance of RBC life, and in this condition, regeneration of glutathione prevents oxidative stress. This leads to hemolysis. It is also common among African Americans, Asians, Jewish, and Mediterranean. And mostly, the condition accompanies fever and back pain. There are two forms: congenital nonspherotic hemolytic anemia. There is hemolysis, jaundice, splenomegaly, and aplastic crisis. This needs blood transfusion. Second is the drug-induced hemolytic anemia. This is caused by exposure to fava beans or drugs such as antipyretics, sulfonamides, antimalarials, and aspirin. About 2 days after ingestion, that's when hemolysis occurs, but this is usually self-limiting. Children must then prevent or avoid exposure to these drugs or foods. Blood smear helps detect Heinz bodies. These are the oddly shaped particles in RBCs, while an RBC electrophoretic analysis is a rapid enzyme screening test. In many countries, including the Philippines, G6PD deficiency is part of the newborn screening program. Sickle cell anemia. This is an autosomal recessive inherited disorder characterized by abnormally shaped elongated RBCs, as shown in the photo on the right. We know that an adult hemoglobin contains 2 alpha and 2 beta chains. In this condition, the structure of the 6th ring of the beta chain of hemoglobin is changed from the normal glutamine to valine or lysine. Because of this, the abnormal hemoglobin has reduced oxygen capacity. Now, when a child releases oxygen, the shape of RBC changes from round and pliescent or pliable to crescent shape, rigid, and inflexible. This change in shape will cause local hypoxia because the sickled cell cannot anymore carry oxygen. This causes continued sickling and will further cause plugging of the vessels. A sickled RBC lives for 6 to 20 days, compared to the normal RBC which lives for 120 days. How does an RBC become elongated and crescent shape? These changes in shape when submitted to number 1, there is low oxygen tension. The higher the altitude, the lesser the oxygen. Second, when there is a low blood pH. So, conditions involving acidosis can also cause sickling of the RBCs. And third, when there is increased blood viscosity. For example, a child developed dehydration or hypoxia, it can lead to further sickling of the RBCs. So, prevention of these three will prevent sickling of the RBCs. A child homozygous have the disease, but a heterozygous one have a sickle cell trait but may still exhibit symptoms under severe anoxia or dehydration. It can be diagnosed prenatally through chorionic villi sampling, percutaneous umbilical blood sampling or amniocentesis, or through neonatal screening. The vaso-occlusive crisis is when the crescent-shaped RBCs clump together, causing agglutination, which then blocks the small blood vessels. These will increase blood viscosity and result in further sickling and hypoxia. We always want to prevent this vaso-occlusive crisis. There are additional types of crisis: sequestration, hyperhemolytic, and a plastic crisis. Sequestration crisis is when there is pooling and the increased destruction of sickled cells in the liver and spleen. Hyperhemolytic crisis is with folic acid or vitamin B deficiency, where new RBCs cannot be fully formed. Third is a plastic crisis. There's a sudden decrease in RBC production with infection. As seen in the photo, normally shaped red blood cells continuously flow all throughout the blood vessels. But if they are sickled, they will not anymore carry oxygen, plus a sickled cell will block and obstruct the blood flow. The following are the assessment findings in a child with sickle cell anemia. But remember that usually there are no symptoms within the first 6 months. Why? Because upon birth, the fetal hemoglobin contains 2 alpha and 2 gamma chains. Until the 6th month, all of the fetal hemoglobin has been transformed into an adult hemoglobin. And the adult hemoglobin is the one containing 2 alpha and 2 beta chains. Sickle cell anemia is a problem of the beta chain, hence no symptoms prior to 6 months. Also, hemoglobin electrophoresis is used to diagnose sickle cell anemia at birth from the few red cells that have already converted to their adult form. Management: acetaminophen or even IV morphine for pain. IV fluid replacement for hydration. Remember, hydration can cause further sickling of the RBCs. Blood transfusion, hydroxyurea. It's a drug that can increase the production of hemoglobin in children. Avoid activities that interfere with oxygenation. Mountain climbing and flying in unpressurized planes. The higher the altitude, the lesser the oxygen. These can also result in sickling of the cells, exchange transfusion, and also hematopoietic stem cell transplant. Remember that a child in sickle cell crisis has three primary needs. This is the summary. One is pain relief, second is hydration, and third is oxygenation. Again, this will prevent further sickling and halt the crisis or the vaso-occlusive crisis. Idiopathic thrombocytopenic purpura or ITP. Idiopathic means the cause is relatively unknown but thought as immune or autoimmune, which means the condition is mediated by the own antibodies. Thrombocytopenia for low platelet count. There's a decrease in circulating platelet. And purpura is the appearance of a purple skin due to bruising and bleeding. ITP may either be acquired or congenital. In most instances, it's acquired. It occurs about 2 weeks after a viral infection such as rubella, rubeola, varicella, or an upper respiratory tract infection. It could be congenital when the mother has had ITP in pregnancy. The antiplatelet factor can cross the placenta and destroy the platelet in the newborn. Figure 44.3 shows an infant with ITP. Note the tiny petechiae all over the body, but there could also be large areas of ecchymosis, most prominent over the legs. There may be also bleeding or epistaxis, bleeding into the joints or epistaxis, and the thrombocytopenia may be as low as 20,000 per millimeters per cubic millimeters. Management is to immediately prevent and control bleeding. One is through drug therapy. Oral prednisone can be given. This will reduce immune response. Second, intravenous immunoglobulin or IVIG or an anti-D immunoglobulin for Rh-positive children can also be given. This will supply anti-ITP antibodies. And third, acetaminophen for joint pain when there is bleeding. Do not give ibuprofen, do not give aspirin for pain. This may cause further bleeding. Second is platelet transfusion. This will temporarily increase the platelet, but the effect is only limited. Third is splenectomy. This may be done only for those with the CNS bleeding, but it is rarely necessary. ITP is usually a 1 to 3 month course. Few are chronic and needs immunosuppressive drugs. Because ITP is mostly preceded by infections, it can be prevented with vaccine against rubella, rubeola, varicella, and other viral illnesses. Hemophilias are a group of inherited blood coagulation disorders where there is a deficit of one or several factors in the clotting mechanism. So please review and go back to the clotting factors mentioned previously in the slide. There are 4 types: Hemophilia A, von Willebrand disease, Crises disease, and Hemophilia C. Hemophilia A is the most classic form of hemophilia. It is transmitted as a sex-linked recessive trait, which means males are mostly affected. It's caused by a deficiency of factor VIII, the anti-hemophilic factor. It's an intrinsic factor, so the intrinsic system for manufacturing thromboplastin is incomplete. Take note that in Hemophilia A, the extrinsic or the tissue system remains intact. Assessment findings include prolonged bleeding, bruising, hematomas but no petechiae, peripheral neuropathies, hemarthrosis with a normal platelet count, prolonged partial thromboplastin time, and anemia. Hemophilia A is often recognized first in an infant who bleeds excessively after circumcision. For older children, bleeding tendencies may not become apparent until they become active, such as when they crawl, they climb, or they walk. In the photo, you see a large or a marked hematoma, which is a sign also of prolonged bleeding. This client has been given intramuscular injection, and because there is an intrinsic problem, there is continuous bleeding inside. Management is to again immediately control the acute bleeding. You can give cryoprecipitate concentrate of factor 8. It can also be supplied by a fresh whole blood or FFB. Factor 8 can be seen in these bloods. Apply ice compress, immobilize area, and elevate affected extremity above the level of the heart. This can provide good blood flow and venous return. Third is to administer hemostatic agents. This will stop the bleeding. Avoid sutures, cauterization, and aspirin. This will promote further bleeding. And desmopressin drug can also be given. This can stimulate factor 8 release. In some children, antibodies to factor 8 develop. So, you must give aminocaproic acid. It's a fibrinolytic enzyme to stabilize clot formation and promote wound healing. In children, they can also be given factor 9 to halt the bleeding. Von Willebrand disease is an inherited autosomal dominant disorder affecting both sexes. It is often referred to as angiohemophilia. Along with the factor 8 problem, there's also inability of the platelets to aggregate and blood vessels cannot constrict to aid in coagulation. In the photo, you will see that with von Willebrand disease, clot formation does not happen as it should. It is considered as the most serious hemophilia. There's prolonged bleeding time, usually in the mucous membranes, and epistaxis as well. Among women, menstrual flow is unusually heavy, and childbirth is a risk for women because of the excessive bleeding. Bleeding is controlled with factor 8 replenishment or the administration of DDAVP. It's D-amino-D-arginine vasopressin. DDAVP is the brand name of desmopressin. Crises disease is caused by factor 9 deficiency. It's a protein which helps blood form clots to stop the bleeding. Again, it is sex-linked. Only approximately 15% of people with hemophilia have this form. Treatment is a transfusion of factor 9, which can be given at homes. You're also probably wondering why it's called Christmas disease, because it is named after Stephen Christmas. He is the first patient described with this type of hemophilia. Hemophilia C is caused by a factor 11 deficiency, which causes plasma thromboplastin antecedent. It is recessive trait and symptoms are generally mild. Bleeding episodes can be treated with, again, giving of DDAVP or desmopressin and transfusion of fresh whole blood or FFP, which has the factor 11 in it.